Hello. Hello and good afternoon. Welcome to another asset session here. Today we are lucky to have a very prominent surgeon and teacher, Dr. Supe, here with us. Dr. Avinash Supe is a prominent surgeon with vast teaching experience in his field for more than 30 years. And he has served as president and chairman for numerous professional bodies throughout India, including for the central government and Maharashtra government.
Yeah.
He has been past president and chairman for Indian Association of Surgical Gastroenterology, Indian chapter of IHPBA, Academy of Health Professionals, Educators of India, GSMC FEMA Regional Institute, Expert Group Medical Council of India, National Medical Commission, and he has been an ex-dean and a director for numerous medical colleges in Mumbai under MCGB. And currently he's in a Director Clinical Governance, Hinduja Hospital, consultant for GI surgeons and Hospital Chembur. As I've said, he has been Director and Dean for Medical Education in major hospitals in concern with Mumbai, Commissioner of Greater Mumbai, and is currently Emeritus Professor for Surgical Gastroenterology and Medical Education in St. GS Medical College, Mumbai. He also serves as a visiting faculty for numerous institutions, including Tata Institute of Social Science for Hospital Administrations. He is on a many editorial board for medical education's Indian Journal of Gastroenterology, Journal of Postgraduate Medicines, and numerous other bodies. He has received numerous awards like Dr. B.C. Roy Award, NBI, MNC, Clinical Teachers, etc. MUHS National Board Awards for Best Teacher, Mumbai Bhushan 2020, Chembu Bhushan 2019, Maharashtra Bhushan 2019 awards. Overall, he has 55 awards from state as well as national and international bodies and forums. And of course, he also has masters in health professional education. So he is one of those successful people who have transitioned from being a surgeon to teaching how to do it, and as well as the administration. I welcome Dr. Supe to deliver a lecture.
Thank you. Thank you so much, Parag. Am I audible here, or do you have to use this? Fine, sure. Thank you so much. I think it's a really pleasure and honor for me to be here. And I understand what I'm going to do. I'm going to give you a brief outline of what is acidity and reflux disease, though it's a purely medical topic. But I'm sure if you have any questions, even if those questions you feel are simple questions, please ask me at the end of I'll try to restrict my talk to about 40 minutes. So I'll give more time for you for the questions, because everybody has these questions. And every day I see so many people in OPD, and in practice we operate, and also all these things, whatever questions you have, we will try to solve and try to answer those questions. Okay. Now, I'm sure everybody in their career or in their life sometimes suffers with acidity. And whether you have a very heavy meal, you eat very spicy food, or you have tensions of submitting your thesis, I'm sure everybody goes through these kinds of scientific issues. You know, I remember previously, whenever I used to, first time when I used to present a paper in a national conference, we used to get a lot of acidity. But over a period of time, this all calms down, because there's a lot of humoral component into all this. So I always feel medicine is one branch where there can be nothing more magnificent than art of alleviating human suffering. And that's what I have been the teacher, and I'm a surgeon for many years. And I feel this is something which I always feel. And today what has happened, we are drowning with information, but starving for knowledge and wisdom. What I realize today, I get in OPD many people with a lot of Google kind of pages. They go and they get themselves, they read so much, and there's some information is pseudo information, disinformation. They get confused. And then they come to us saying that I have not been well. So how do I do it? And that's where I think we should be trying to look at this, because information today is not very difficult. With all, I'm sure all of you must be using Perplexity and Nova and ChatGPT. So getting an information is not so easy, difficult today. What is important is how do you analyze that information and how do you convert it into practice? And that's where I think the wisdom comes into picture. So for very beginners, I'm sure I was going to tell you that we have, this is where is mouth, and this is where we eat food. This is our tongue, which can come out. And then this is esophagus. And this is stomach. And this is duodenum. And this is the gallbladder. So mainly the disease of acidity and reflux disease are related to the stomach and esophagus. And this is basically they are related to that. Now, what is acidity actually? Acidity and reflux disease commonly known as GERD. I don't know how much you know. Anybody has heard this term GERD? Many of you has heard, yeah, getting GERD. That means what is a gastroesophageal reflux disease. Involve chronic symptoms caused by stomach acid flowing back into the esophagus. So acidity is where you create more amount of acid, and when it flows into your esophagus, we call it as a reflux disease. And normally there is a reflux which can occur because of the loose sphincter, or sometimes it can occur because of the volume reflux. When if you eat too much, for example, on a Sunday dinner or in festival dinner, you eat up to almost here, or a free dinner. At that time, you always find that sometimes you get those burps or something which comes out even after 4-5 hours. That's all volume reflux. And so there are always two types of refluxes. One is the normal reflux, and other is a volume reflux. So what are the signs and symptoms of reflux and acidity? I mean, I'll go briefly, but I'm sure this is purely a big topic. So if you have any specific questions, we'll try to answer them in a typical way. So typical symptoms are a heartburn, burning sensation in the chest, regurgitation, acid or food coming up. Classically, patients will come and tell me that I had eaten something which is coming up in the night, whatever I have eaten. And that is a kind of a symptom which you normally ask them. And dyspepsia, that is upper abdominal discomfort. They get pain after food for about 2 hours. And this is very commonly seen today. I mean, 30% of our OPD is acidity and gastroesophageal reflux. So different kinds of levels of that we get it. And a typical manifestation is a chronic cough and hoarseness. Now, this is something which I have seen more in teachers who talk a lot, or people who talk a lot, and they have an acidity, then it would affect, and that would give them chronic tonsillitis. And sometimes a chronic kind of an infection, and their voice would suddenly change. Sometimes I feel if you go and do their bronchoscopy, there is a lot of thickening and redness of their bronchi. And therefore, the trouble is acidity, but they are treating cough. And they would say, I have taken many cough things and this is not going. They say, I have taken 10 bottles, I am not happening. They have no fever, they have a hoarseness of voice. And the commonest cause is acidity can give rise to these atypical symptoms. And this is where they always come with chronic cough, hoarseness, asthma-like symptoms. Many of these people young people can get asthmas. Even elderly people can get asthmas because of acidity reflux. And this is where they are not diagnosed immediately. And then over a period of time, you get diagnosed. And non-cardiac chest pain. Now, this is something which is very important. Like a young male comes to you and he has a pain here. Everybody thinks it's a cardiac pain. And then they go on getting evaluated. ECG is done, 2D echo is done, angiography is done. And many times you find, because that is such a risky thing. So in emergency, everybody wants to do that. But after some time, if everything is normal, and then you talk to him quietly, and then you evaluate many times, you will get sometimes the reflux is a common thing. So we need to look at this both sides. That means doesn't mean we have to forget about cardiac symptom. Cardiac is one which everybody evaluates first, because cardiac pain can kill somebody within hours. Reflux, it can go on for a few days, but sometimes it is mimic in such a way that I have seen many patients with acidity and GERD, many doctors, I must tell you, are admitted in ICU because of the acidity and reflux. So we need to keep that in option. So if you have somebody has a pain, which is excruciating pain in the lower part of the chest, anterior chest, or in the heart, you have to think this could be another diagnosis. So first look at the pulse and everything. If there's a cardiac, is the first thing which you evaluate. But if you rule out cardiac everything, then look for other causes, which we call as a non-cardiac chest pain. Now, what are the alarming signs? I'm just going to give you a glimpse of it. Yes.
Occur like exclusively, or they are generally or have to be paired with The typical symptoms.
Not necessarily. They can occur on their own, only atypical. So I must tell you, one of our professor of surgery way back, that time endoscopies were not, people don't wanted to do endoscopies. It was a thick scope and all. So he suffered from this pain, admitted in ICU for 3 times. And that time we had to do nuclear scan that time. And we put that gastric and then we saw the reflux coming up. At that time, the even pH meter and all, they're not available. So atypical symptoms may not be associated with typical symptoms. They can be standalone symptoms. And therefore, that's the reason it makes it difficult for you to diagnose. So first, in such a atypical symptom, you would like to rule out ENT cause, cardiac cause. You'll have to go through this. And then if it is not there, then you can go through these kind of things. That is something which happens. I remember I was a dean and director of KEM. That time I got little severe chest pain, same thing. I'm involved in all this, still it happened because of the stress and all that talking you have to do as a dean. And one day, one of my teacher, now he's very senior, about 75, 76 years old. He took me and he did my endoscopy and he showed me how it was all red. And then I was on steroids and painkiller, this acidity antacid for almost about 2 weeks or 3 weeks, and then it all settled down. So I think sometimes these atypical symptoms can manifest without even typical symptoms of acidity. And this is all you should really remember that way. What are alarming signs when you are really working with this? You have to think, if a patient comes to us with some symptoms, like he has a difficulty in swallowing, this is something which you have to worry. Has it formed a stricture? There's a tumor there? Is it causing any problems? So that is where it needs immediate endoscopies. Then unintended weight loss. Somebody loses weight with acidity. It's not something which you should take it lightly. Okay, so 4 or 5 logs is not intended. This is something you should worry. Or vomiting blood. These are complications of the disease, like it has formed a stricture or Barrett's esophagus. Barrett's means it can form multiple ulcers at the lower end of the esophagus because of this acid. Because see, ultimately, all of you are scientists, so you should realize that acid is well accepted by the stomach. But when it comes to the esophagus, esophageal mucosa is not ready to accept acid. So it is going to form some kind of a reaction. The commonest it causes is what is called as an erosive gastritis. Many of you must have already suffered this erosive gastritis. You do endoscopy, sometimes you get H. pylori positive. You have erosive, means redness is there. It's a mild one. Then it starts making multiple ulcers. And then it can go into, there's something called as the Los Angeles classification, A, B, C, D. If it goes into the D, that means there are multiple ulcers, and when they heal, they form a stricture. And that's the time patients will come and tell you. But sometimes we tend to ignore this and we continue with eating multiple these medicines, pan and saying everything. People go on taking for months and they have your work there. Work we sometimes give more importance, and then we land up in all these kind of complications. So what investigations you normally do for acidity? Endoscopy is a gold standard for assessing esophageal damage, like erosive esophagitis and Barrett's esophagitis. If somebody has if somebody giving a regular medicine, if it does not get well, you must get an endoscopy. So normally what patients come to me, like say in my OPD, you will find every day about out of say 20, 25 patients, you will find at least 7, 8 patients have an acidity or reflux disease. This is become so common today in practice. And I'm a surgeon, you must realize this. For a physician's practice, it is much more. And these all patients, usually, we don't do for endoscopy. We will first put them on medicines. We will give them a course of medicine. And then within about 3 weeks or 4 weeks, they don't get well, or there are atypical symptoms, which I cannot explain, or there are alarming symptoms. Then we will go for endoscopy. Okay? And this is where we should do. And we look for erosive esophagitis. pH monitoring is we measure the acid exposure in esophagus for 24 hours. Now, this is those patients where you are not able to differentiate between the pain because of the acidity versus cardiac pain. Those patients where there's a lot of dilemma, what we do, we put a pH. There are different kinds of now pH metries. There could be a remote place. You could have catheter-based. And then we give a patient a kind of a button. So when he gets a button, he gets a pain, he will press that button. So we see the spike. If we see simultaneously spike of acidity in his esophagus, then we know that has probably caused the pain. So then we start making that clinical correlation with that, So it's a little advanced thing, not commonly done. Only if patients has a dilemma or difficulty, then only we'll use this. Otherwise, endoscopy would probably give you a proper diagnosis. Esophageal manometry, especially if you have a lower esophageal sphincter, it's normally we do have a transducers, we put it, either there are many transducers and we try to look at the motility and try to see how much is the stricture. And then if necessary, we have to think about surgery. And suspected Barrett's esophagus or cancer, then we always do biopsy. Just to find out what is the grade of this esophagitis. Do we need to do anything further? Then we'll definitely do a biopsy. Now, what are the treatment strategies for acidity? How many of you have got acidity and what treatment you have taken? Antacid. Okay. What else? I mean, you look very healthy crowd, but anybody has suffered from acidity? Yes. So what have you taken, sir? What kind of a treatment strategy? Rabiprazole. Fine. And that's something which mostly people do it. It's a very commonly taken medicine. I think now a commoner also takes Pan 40 or Pan D and everything they take. And it is across the counter in our country. So anybody can walk in and take it and they feel very happy. Yeah, it's Pandilia or something like that. They even try it everywhere. I mean, you go anywhere on travel, people have that is done on their own, they take it. Now, the first strategy is a lifestyle modification. What all you advise basically. Elevate the head of the bed, that is mainly for the GERD. Avoid meals 3 to 4 hours before bedtime. This is a good policy for everyone. I mean, those who have acidity and reflux disease, I would advise you that have a meal about 3 hours before meal. I mean, have a meal and then see IPL match. That's a better policy rather than having meal at the end of the IPL match. It's a good policy which everybody should try. And if you have, say, meal at around 7, 8 o'clock, 8:30, 9 o'clock, which most of the time you will have, and most of you may be sleeping at 11 o'clock, then that's the best time. And meantime, sit up, don't lie down. And that's the big policy. Weight loss for overweight patients. Now, see, many of us have seen acidity and reflux go along with the obesity. That is what happens when the people are very thin and they are doing properly their exercises and their tone of the body is good, then usually the reflux doesn't occur so often. But when people start becoming obese, the first thing happens is their sphincter starts losing and they become obese. And many times I've seen people have gained 10 kilos or 15 kilos. They start getting this small amount of refluxes because what is the fat? Muscle tone, diaphragmatic tone, everything. So this is where you will find overweight. So many times when people have obesity and a reflux disease, many times they ask the first question, are you ready to undergo obesity-based treatment? Then that time only they will take care of this. But otherwise, you try to reduce weight, do pranayam, do Brahma Vidya, try to improve tone of your muscles. That would probably improve the reflux disease. Okay? And of course, quit smoking and limit alcohol. This is what advice we normally give to the people for the reasons. Smoking itself is a very contributor to all these erosive esophagitis and esophageal Okay. Now, there are mainly the medications which people take are 3 levels of medications. Okay. The first medication is antacid. It's a short-term relief for occasional symptoms. Now, previously, before 1980-85, antacid was the only thing which was available. When I was a student, you remember about 45 years ago, what we used to give patients were what is called the Supe's diet. And that diet included giving them milk every 2 hourly. Imagine, we used to put a tube and we used to give 2 hourly milk. And that time patients of peptic ulcer disease used to get this Supe's regime. But what is the problem with these antacids and milk therapy? It reduces the acid for a short period of time. And then after 2-3 hours, there will be sudden rise of acidity. And that when you suppress it for some time. So what does acid or these antacids do? They will only neutralize the existing acid in the stomach. They will not reduce the content. And in fact, if you reduce it for some time, they'll improve the pH. But after that, as a response to the body, as a hormones, the acidity will grow very high. And therefore, you have to either take it 2-hourly or 4-hourly, which becomes very difficult for them. And that's the reason you find people say, I have taken it, I felt better for some time, and after that, it has come back again. So this should be only supportive today rather than the only therapy. The second is H2 receptor blockers. I won't go into more details of this medicine and the way they act and all, because these block their H2 receptors in the stomach. Now, this is suitable for mild and intermittent symptoms. It has faster onset but less potent than PPI, reduce acid secretion and take some time to start. For example, if you have a severe pain acidity and you take ranitidine or cimetidine, famotidine is a better thing which you can give it to patients who have a renal failure. It won't start immediately. It would take some time, 3 days. And then you feel, oh, I have taken these medicines, but I'm not feeling better. Because it takes some time for it to really act. And what does it do? It blocks the H2 receptor, so it reduces the acidity to some degree. But the most commonly used drugs today are the proton pump inhibitors. That means it began with omeprazole, pantoprazole, rabiprazole, esomeprazole, all these brands which you use. Now, what is the difference in them? Omeprazole was the first brand. Then came pantoprazole because pantoprazole has less amount of drug reactions. For people who are taking multiple drugs, pantoprazole is better. Rabiprazole is better for them. Those who have esophageal symptoms, they take esomeprazole. Many of you must be taking Isomac, Nexium. All these drugs will take care of the reflux also. So these these rapidly heal the erosive esophagitis, but not ideal for long-term use because they are very strong medicines. Those people who take this pantoprazole for long period of time, many times get fungal infections. After 8 months or 9 months, you do their endoscopies, you will see all fungal infections because you are cutting down the acid. See, acid actually is good for food. People like us, people like us don't eat at home every day. We are exposed to so many bacteria when we eat outside, water. Now, acid is something which is good because it is going to kill all those bacteria. And we are cutting down that acid completely, then those are the people who may get diarrheas. They may get loose motions. Their abdomen gets disturbed. So we need to have some level of acidity maintained. For a short period of time, yes, but not for a long period of time. And the new molecule which has come, which is called as a vonoprazole. Now, these are all sodium pump blockers. This is potassium pump blocker. This is the recent addition. Last 1 year it has come. Of course, there are new molecules are coming, but this is what has been approved by US FDA last July, and it has been used extensively in India now. So many of you have got recently to the doctor, they would give you Vono or Vonefi or vonoprazole. Now, this is something which also takes care of your reflux. It also takes care of your H. pylori, and it is better for thing. But of course, there's a 6 weeks course. After that, you have to really reduce it down. Okay, so these are the common medicines which we take. There's a surgical treatment, which normally for reflux, what we do, I will come back in a little later. But fundoplication is one surgery which we can do technically. We can do these surgeries and we can wrap it. We can create some degree of an wraps so that we recreate the sphincteric effect. Now, these are done only in 1 or 2% patients with acidity or reflux. Only 1 or 2% patients. And the patients have to earn surgery for themselves. Ideally, this is because you do it through laparoscopy today. So these are different kinds of fundoplication. So what is dietary advice? And this is something which is always interesting for any person, What we advise is avoid triggers, very spicy, fatty, acidic food. Caffeine, chocolate, mint, and carbonated beverages. Now, I always feel those food which is highly osmotic, once it goes down, it will increase the volume reflux. For example, you try to eat about, say, 5 gulab jams or 10 rasgullas with high amount of uh, that ras, which is highly osmotic syrup. Now that will draw so much of water, you'll feel thirsty. So you'll start drinking a lot of water. Then chocolate gravies, all those, or the pav bhaji rasa, they all are so concentrated, which all of us eat, I'm sure, but you can cut down on that, especially if you have acidity and GERD problem, because it will induce volume reflux. It will induce acidity. All this food which is likely to cause. So eat in what we call it as portion control. Try to do portion control in this, especially, or balance your food. Many people would balance. See, classical Indian meal was so good. Actually, if you see, varan, bhat, and त्याच्यावरती तूप. Tooth is excellent for this kind of thing, because it covers some kind of a thing. And if you really, so we have a good amount of roughage, we good amount of acidity, we must good amount of food. So balance was good. But today what has happened, we have changed over to the westernized diet. And that's the reason we are finding this more coming up. Smaller frequent meals reduces gastric pressure and limit late night snacks, minimizes nocturnal reflux. Many people have a habit of eating late night nocturnal snacks. I think this is something which can also give rise to acidity. Okay. Long-term drug side effects. What are the long-term side effects? Now, many PPIs, if you take very longly, it can increase your creatinine. It can cause kidney injury, chronic end-stage renal disease. Patients who have chronic kidney disease, there you should not take long-term PPIs. There is better to go for famotidine. Even don't take ranitidine and cimetidine. It's better if somebody has a creatinine is slightly higher, 1.4, 1.9, 2, it's better to give famotidine instead of giving the omeprazole or something like that. Cardiovascular, increased risk of myocardial infarction and stroke, higher susceptibility to diarrheas and pneumobilia. And I told you this is because we are cutting down the acid. So because acidity is controlled, external bacteria come. This is the typical organisms which are from outside, they come. Then you have nutritional deficiencies like hypomagnesemia, vitamin 12. This is because you have a changed kind of a microbiota. If you all know how much work has been done on microbiota, and all of us should see to it that how microbiota is good for. So if you're eating all this, I remember in Maharashtrian weddings, if you go and you eat jalebis, they give one of the best kind of drink which is called as mattha. And what is mattha actually? Mattha is nothing but they take 1 spoon of curds, put it in water, mix it, make a very light buttermilk and give them tadka of hinga, jeera and halad. Now that is so good for microbiota. And therefore people used to eat 50 jalebis and have mattha and it used to get digested. Now in today's world, we don't even touch jalebi. We have come to a stage where we don't touch jalebis. But that was a kind of a PBS, in Pankti, they used to have these competitions. But after that, they used to have. So some of these solutions, like if you eat too many bananas, best is to eat elaichi. It will digest it. So these are all kind of an contra kind of working which work. So these are all something you should do. And of course, you can get dementia, hypergastrinemia and all these kinds of things. So if you really see, H2 blockers can give rise to headaches, diarrheas, rare but severe confusion, cardiac arrhythmias, and tolerance. So normally, don't get so worried about all this. There in our textbooks, it is always written in a big way. But if you have prominent symptoms like this, then you have to think about it, whether it is because of those. So what are the key takeaways? We have to go prioritize lifestyle, diet changes before long-term medication. What I would thought, instead of going for a long-term medication, think about diet change and lifestyle change. You may be able to avoid going on this acidity for a longer period of time. See, many people have habit of taking PAN for, I have seen people taking PAN for 8 years, 10 years, 12 years. Now that is too much. 6 weeks course, 3 months course is fine. After that, you should try to get rid of it. And this is something which you should always do. Monitor long-term users, regular renal functions, magnesium levels, bone density, because they can suddenly come with fractures. and we need to think about this. Reassess necessity, periodical, evaluate if continued medication is required. Many times it could be a psychological barrier also, that if I have not taken pan, I get acidity. So try to train your body. What we many times tell patients, try to take it on alternate day, try to reduce your dose or take it twice a week and slowly cut it down. It's like a small addiction only. So you get rid of that addiction. Surgical referral, consider all patients with refractory symptoms, Barrett's, malignancy, complications like strictures. All this require a surgical kind of a referral. Okay. Now, when you talk about GERD specifically, this is kind of focal ulcers you get. If you take patients, circumferential, they could be circumferential means all along. This could be focal ulcers. So many of our patients who take severe esophagitis can get pictures like this. And we see this very common. I mean, if you see our endoscopy room, you will see all these pictures very common in our day-to-day. So these are not so uncommon, except for these are not so common, but these are very common pictures. Okay. What are the danger signs? Difficulty in swallowing, weight loss, black stools when patient is bleeding, and your family history of cancers. If you have somebody in your family, your mother, father, brothers, then think about it, having endoscopy faster. This is a kind of a Barrett's disease. This is type 1. Acid burns, sometimes you can get esophageal ulcers. And what surgery is done for the reflux is called as a fundoplication, mainly treated by medicines and dietary modification, but surgery should be the last option for these patients. And what we normally do, what are the newer techniques in surgery? Now, what has happened previously, we used to do surgery, and now also we do surgery laparoscopically. That means what? We put multiple ports and we do this release. We try to tighten the sphincter by creating fundoplication. This is a very commonly done surgery. But today, a lot of new techniques also have come. Many people are working, not those done so commonly in India, but today they have started now, especially what is called as an transoral incisionless fundoplication. That means what? You put a scope, and if you want, I can show all these pictures if you are willing to see. But some of these can be done. Minimally invasive procedures where endoscope creates a wrap around the lower esophagus. It's totally without any scars. This can be done. Then there is another called strata. This surgery where you use radio frequency energy to tighten the muscles of LES. You cause multiple small burns and do a controlled kind of a fibrosis. Then these are all another called as the links. These are ring of magnetic beads is implanted around the LES, and then you tighten them. So the sphincter which is loose, you tighten it by putting magnetic beads. So these are kind of techniques people use now. Okay. I'm sure there are so many new, like say there's called as an anti-reflux mucosectomy, peroral endoscopic cardiac constrictions, endoscopic submucal dissections. All this now AI is coming into picture, and they manage the depth. They try to help you. There's a new technique called as endobricks. You just pass that and you take all this and you can really control all these kinds of fineness of these surgeries. So all this is coming up in a big way. But in India today, as I said, if you have 100 patients, 98, you will try it with medicines. 2 or 3% will go for surgery, out of which most of the surgeries are laparoscopic fundoplication based on kind of this. 1 or 2% people are trying out with these kind of new techniques, but these are still not standardized. But I'm sure you will read this in various of your searches, and therefore I thought I must really tell you about these kind of surgeries. Okay. And laparoscopic fundoplication is something where involve the wrapping of the top of the stomach, and there are different kinds of techniques which are there. These are minimally invasive, and they reduce your PPI dependency after surgery, and they improve your quality of life. And that's where you would like to do these kinds of surgeries, Another thing which is there of fatty liver, which I will not go, which is commonly associated with this acidity and GERD, most of the people who have a lifestyle issue. So what comes with is the fatty liver also comes many times. It's a syndrome many times. You have a reflux, you have a fatty liver, you have a diverticulosis. These three have become very common in our country. Once upon a time, we never used to see this when I was a student. But today, with the all westernized diet, all those Western diseases are now come. If you really see MASH or metabolic liver disease, what is called as, this is the new thing which we, in fact, in our centenary, we asked Amitabh Bachchan to come and open this NASH OPD because so many patients need to undergo this. And that's the need, because many I see young or middle-aged women they're coming with cirrhosis because of, again, lifestyle modification. And this all can be avoided if you try to do this lifestyle diseases. Okay. Anyway, I'll just.
What was that?
Which one? Which one? This one. This is a cirrhotic liver. This is a NASH causing nodularity, and this is becoming cirrhotic. Okay. Another thing which I just wanted to show you was H. pylori. I'm sure H. pylori is something which is very common. And if you really see H. pylori, it comes in all water and everywhere. And if you test, if I go and do endoscopy of all of you, almost about 80% I'll get H. pylori positive. But the question is, if it is not causing any symptoms, it's a common cell, we don't need to treat it. But if it is causing an erosive kind of esophagitis, erosive gastritis, then it needs a 14 days course. And so how do you can prevent these kind of things? What I would tell my patients, I'll tell you. I tell them that you eat outside, but eat something which is hot, which is made in front of you. Like if I want to eat samosa, I'll eat samosa, but I'll not eat chutney. Because I don't know when this chutney was made and where it was lying, cut fruits. All these are most dangerous. So if you want to eat dosa, sambar is the best thing. Vada sambar is the best thing. Samosa, because these are fried in front of you. Make chapati in front of you, you can eat it. Don't eat something which is there, not there. So this is if you go to in marriage, remain away from the sharbats and all those. These are something which we don't know how they are made. Bottled drink, I understand. But when it is people, the way you use it, this is where you get H. pylori infections very often. Okay, so that's a simple method. And I think I'm taking time. So anyway, this is the kind of a barrier. We normally have this diaphragmatic thrust. We have this basal pressure. This is lower end sphincter tone. And this is a diaphragm. And this is pressure which goes up. Normally, the esophagus has a higher pressure than the stomach pressure. So normally the food doesn't go. But when the sphincter becomes loose and this pressure becomes high, then the fluid will go. Otherwise, it is always one way. So it's a purely pressure. The body controls it with the pressure mechanism. So when this sphincter becomes loose, that's the time it starts becoming reflux. So it could be a volume reflux because of just load, or it could be because of the pressure reflux. So what we normally try to do is we normally correcting that pressure by surgical procedures or endoscopic procedures. All this is what is the philosophy of all this, and then I will just skip all these things, and I'll try to show you the newer kind of a guide. Let's not go into guidelines, which I told you most of the thing. Okay. So this is the way we dilate these kind of strictures. We put stents sometimes for the strictures. And this is a Barrett's. See, this is the way you see all reddened kind of a thing. And we normally try to, this is Barrett's with low-grade neoplasma, and this is early cancer. So all these early cancers today can be treated with endoscopy. We don't need to go for surgery. And this nowadays AI also helps you to diagnose it, and it will help you to remove all this also. I think some of the countries, if you go like Japan and all, Korea, Japan, first time I remember I went to Japanese Tokyo Medical Center, somewhere in way back in 88 or something. That time, when they were doing endoscopies, that time they used to take 24 Kodachrome slides of each patient to identify whether it's malignancy, because malignancy is very common. And then over a period of time, NBI came, where now with endoscope you can diagnose which is the area, and then started taking biopsies and all. So now the science is so advanced that we can easily find out where is the early gastric cancer, and we can pick them up. So previously, for many years, early gastric cancers were never detected well in India. But now we have started picking them up. So if you have a high risk and your patient has a danger symptoms or alarming symptoms, then if you do endoscopy, sometimes you see a small where you can excise that, and patients then live long because you have diagnosed them early. Okay, so that is the whole science behind all this. Okay, then what you call as a chromoscopy. You do these chromoscopies. You inject various kinds of dyes, vital, and then you can know which areas are dangerous, and you can take biopsies from them. And this is contrast chromoscopy, indigo, carmine and all. We use all this autofluorescence. You can do narrowband imaging. This is called as a NBI, villus ridge with patterns with macrovascular. And this is now has become practically all these argon beam therapy and photodynamic therapy are done in most of the hospitals. NBI and narrowband imaging is done in practically every hospital today. Like most of your endoscopes have this narrowband imaging. So diagnosing a cancer doesn't become very difficult today. And we can do radio frequency ablations. We can really do all this. And anyway, I'll just, so this is something which I told you, the kind of surgeries we do. And this is the way you do endoscopic wrap. You look at the wrap after surgery. And normally, what are the lessons we learn? Let the patient earn surgery rather than you pushing him to surgery. Then learning curve. Most of the surgeons are not used to this surgery, so you must get it from an experienced person. And pre-op manometry and center of excellence and concerned about long-term PPI. And I wanted to show you some more slides. I think I'll just try to release this and go into the... If somebody was interested, I thought I got these slides, but these are not really necessary. And just give me, I think so, 1 minute. How many of you work on all these areas? Anybody's working on these areas in your field? No? Do you have surgery? You have biological and these you do on this kind of things? Okay. Okay. These are the other causes of ulcers, gastrinomas. These are small tumors of creating acid, alcohol, aspirin, and NSAIDs, bile acids, and helicobacter infection. One of my teacher, Dr. Dhanuka, did a wonderful study on Kolhapurchi mirchi, how many ulcers it causes. And what she did, she took Kolhapur mirchi and she asked, that time we used to use dogs very easily. That time there was no PETA and all. So we used to really do, and we asked humans. And then we used to really see what was the damage it caused. And it used to cause a lot of damage. And, sometimes then after that, I've stopped eating Kolhapurchi mirchi. You understand? So this is stiff, this is one surgery where you put an endoscope like this and you put clips like this. So this you are recreating the sphincter. This can be done with endoscopes. You don't need surgical for this kind of a thing. This is called as a TIF, total intraoral fundoplication, what is called as trans-intraoral, it is called as. Then this is a strata procedure. You are putting this balloon and then you are injecting with radio frequency. So when this heals, it becomes little tight with fibrosis, like scarring occurs. And this can prevent your surgery, reflux. And then this is the links, you put a metallic kind of a thing around like this. And you can loosen it, tighten it with the help of external sphincter. And you can see how I can really do this. That's the way you can prevent reflux. Very interesting procedures. But as I told you, these are all still in research. Some of them people are trying, so I won't advise you immediately all these procedures to be done. Okay, this is arms where you use what is called as in the radio frequency, and you burn these mucosas, and then over a period of time, and you put multiple clips, and then they heal basically. And endoscopic submucal resection. This was I was telling you. Now you do these procedures endoscopically. So small cancers are already removed like this today. This is the way you do it basically. And per oral cardiac constrictions, you can pass endoscope and take sutures. Now there are endoscopic suturing machines which are coming, which you can do this. So I think what I'll do, I'll stop here and I can take questions from you, whatever you want to really ask. Anybody has any questions? And I'm sure we can take all these questions.
Fasting and acidity.
Yes, many times if you people do a lot of fasting, they normally, if they are used to, for a long period of time, they can get a small amount of acidity. But if you eat a good food, I'm sure you get more amount of acidity and you don't eat it. That's the problem, okay. Because it is going to stimulate it. If you're fasting, you see a lot of food around you and you don't eat it, it's going to stimulate your brain. It's going to cause more acidity. So I think if you going to see a lot of good food, better to eat it. Make sense? Sure. So people have fasting. Many times people have, if you fast for a long period of time, then people take medicines today.
A lot of people suffering from asthma that get also acidity and gastric reflux.
Asthma-like symptoms.
No, as in, so people already who have bouts of asthma, are they also prone to get acidity?
Many times people now evaluate them. If your pH is high, acidic, and manometry is showing a lot of pH reflux and all, then you first treat that, and you will find many patients' asthma symptoms will go away. Those who have a genuine asthma with spasm, it's okay, but this acid acts as a trigger. So you look at the type of symptoms. Do they get it after meal, after 2 hours? Do they get it when they lie down? Do they get it? What kind of symptoms they get it? And then you look at their pattern of your symptoms. And then you do investigations. You can put some degree of an scope and see, or you may do manometry with pH meter. And then if you find out you have a reflux, then treat the reflux first. Treating reflux is easy. And with that, his symptoms go away. Then we know it is the way it is. Many children, and don't underestimate that children do not have acidity. Many children have acidity. Acidity is common in children, 7, 8, 10 years and all. So treat them if you have. Many of these asthma-like symptoms will go away. Yes, sure.
Thank you for informative talk. This is not directly related to acidity and reflux, but since you showed so many pictures of the liver and cirrhotic conditions, there has been a lot of debate recently, especially on Twitter, etc., on the efficacy of herbal formulations like Live 52. Are they actually useful or are they potentially hepatotoxic? So,
Liver 52, I really don't know, basically. I mean, these are all things which are never tested.
they're never tested. That's the main argument, that most of these medicines are not tested.
See, what I feel, we had a big Ayurvedic research lab in KEM. So we used to do a lot of these testings, and scientific testing we used to do. So what we really found that Google is not very risky. Bhasma is risky. Most of the people who take Bhasma, see, there are these about this liver, no, you should really remember what these Ayurvedic people give. If you're taking a Bhasma, be careful. Because Bhasma could be Soneri Bhasma, that could be silver Bhasma, Tambyacha. They all cause heavy metal poisoning and they can damage your kidneys. If you are, most of these liver medicines they give, I've seen many people getting jaundice. They first go to this Ayurvedic fellow, they take this pala or some juice. Most of them have steroids. And steroids help them to reduce edema. So if you're taking a short-term steroid, it is not very risky. But Bhasma on a long term is dangerous. I don't think liver 52 has any metallic thing. So we don't know. Really, the answer is we don't know. So people have been using it for years and the companies have been marketed, because in our country, nobody can block an Ayurvedic medicine. He has to only show that there's a reference into Charak Samhita or Shushruta Samhita, and the medicines are allowed to be sold. So people have been using all these combinations, and there have been the studies which have been done are never robust studies. They will do some studies and they'll show this is improved or something. They're never good studies. So we never know the right answer. So the answer is, if you take it, there is no damage, but I don't know how much beneficial it is. Thank you.
I had a question. You said some foods trigger this thing, acid reflux. Okay. So I know some people who are getting affected because of eating raw onion, katsa kanda. Eating that causes acid reflux extremely badly. So
Yeah,
how
anything
does that work?
raw stimulation, ultimately it stimulates, they get triggered because of this. If you eat really strong onion, it's ultimately a kind of a smell which is going to stimulate your acidity. Now, if you know how much truth in that is, you'll have to, as you know, you'll have to do that study. But I get many patients who say that if I eat kacha kanda, I get this acidity. But that is because of the raw onion has more stimulation. No, it stimulates through your gas or ammonia or whatever kind of those things.
That's already a known thing.
They are known thing basically.
You said obesity also causes this. So what is the correlation?
Obesity, when people have morbid obesity, that means they have BMI, which is more than 30, 35. What happens? Their body habitat completely, body shape changes. Their diaphragm and the esophageal junction becomes more loose. And they get simultaneously higher acidity. So we asked, there's actually an algorithm. I did not show you that, but there's an algorithm which says, do you have... No, I did not put it. But there's an algorithm which really says, do you have obesity and are you undergoing obesity treatment? Then simultaneously we treat your acidity reflux also. If it's not there, then we'll do fundoplication. Otherwise, when you do a obesity surgery at that time you can take care of this sleeve and then you can put bypass and also you can cut it down that way. So obesity, morbid obesity goes along with the reflux because it loses your sphincter and loses your tone of the body. This is all, see, this is all based on your pressures, no? Esophagus and stomach is all a pressures. Stomach has a low pressure and the esophagus has a higher pressure. So in spite of being that way, so it doesn't reflux. Actually, if you see, thoracic pressure is lower, abdominal pressure is more, but esophageal muscle and the sphincter keeps it pressure higher. So if that balance is lost, people are going to get this. Therefore, obesity changes your body shape and then it changes the whole pressure system. Therefore, it changes all this. Type A personalities, stress, these are known to cause acidity. This is a typically your hypersecretors. I did not go into genetic part of this. There are so many people who are highly genetic in causing acidity. There are so many people who are A personality, tension personalities, those who are stressful personality. Acidity goes with them. It is a kind of a stimulation, gastric secretion is more with them. And we see it very commonly. I mean, those people who are highly stressed, and you're all scientists, so I'm sure the stress and anxiety is much higher in your group. I had done one study, which is very well quoted study. I think you can go in the net and find out. It has more than 600-700 citations. I had done a study on stress in medical students in KM hospital. We had found so high number of stress, and some of thing was pathological stress because of the exams and academic pressures and all that kind of thing. So I'm sure all of us continue to see, but how many are secretors based on your personality and other factors? So you can control other factors. You can control stress also. So I always feel now what is very commonly being talked about today is mindfulness, environments, medicines. These are very important for an organization. I think what happened in Kolkata, if you know, that one lady was raped and all that kind of thing. I remember government of West Bengal called me 2 months ago and they had called 400 people from all deans and all. And they were only trying to work on how do we improve the environment into these medical colleges? How do we make it more safe and learning environments? And then I find when people are working in a stressful life, especially like our residency, people don't have time for having food. They work for 110 hours a week, all patients, all kinds of stresses. They are bound to get this acidity. So we need to see how our... So what I tell many patients, 30 minutes of meditation and 30 minutes of exercise. That is always, whatever your schedule is, take out these 30 minutes of exercise and 30 minutes of your meditation. Meditation could be of any kind. You can do yoga, you can do music, you can listen to classical music, you can do everything, and that works. So that can reduce your stress.
Thank you.
In your slide, you have mentioned that to reduce the acidity, quit smoking and limit alcohol. That do you like to do? Why you should not quit both things?
Both of them are triggers, well known. Smoking is good trigger. Smoking is a well-known trigger. Limit alcohol, I said. I never told you stop alcohol. But the whole idea was that these are the things which patients don't follow. So you have to tell patients what they will follow. But smoking is definitely the kind of smoking you do, I mean, it was a very classical, even if it's a medical school, people used to, I remember in my hostel lobby, I mean, I have never smoked, but my all students, they used to have in the first week of the month, they used to have 555. Then used to come to Wills, then used to come to Charminar, and last week was BD. And I've seen my all colleagues going through all these phases. So if you look at the effect of this, there are studies which have done that if you eat a very strong tobacco and all this causes more amount of acidity. So therefore, you should restrict it down. Alcohol is a small amount of alcohols don't cause so much. But if you take a large amount of alcohol, it can cause gastritis. And you see so many patients of alcoholic gastritis come on the next day of the new year, or we see all in the whole morning from 12 o'clock in the midnight to next day morning 8 o'clock, we'll have 50 to 100 patients of gastritis until almost 48 hours will go on. It's a very common thing to see. So therefore, I told you limit alcohol. Okay.
Are there any other questions from the audience here? Anybody on a Zoom have a question? They can just raise their hand.
She has a question. You have a question? No, I'm sure you can send me mail also. My mail is well known. I mean, avisupe@gmail.com. Get it on the net.
Anybody on a Zoom has a question? They can just unmute themselves and ask. Okay, I don't think there is any questions being posted. So thank you very much once again for a wonderful talk on acidity and reflux and things. And I welcome everybody to please join everybody in that tea.
Yeah.